Hi everyone, I'm Julianne Bardaly. Welcome to Lurie Children's Facebook Live. Today I'm joined by Dr. Val Cohran and advanced practice nurse Katherine Brennan. They're both from our Intestinal Rehabilitation and Transplantation program here at Lurie Children's. And within that program, they're part of our overall transplant center, which is the Saragusa Transplantation Center. The center ranks among one of the top pediatric transplant centers in the nation. And on average, we perform 50 stem cell transplants a year and 50 solid organ transplants a year. Being that April is National Donate Life Month, we thought it would be a great opportunity to talk about organ transplants and specifically the small bowel transplants here at Lurie Children's. So to get things started, thank you guys for joining us.
Thank you.
Thank you.
What type of transplants do we perform at Lurie Children's?
So we perform, there are 5 programs here: heart, kidney, liver, intestine, and also the stem cell program. The others are primarily solid organ transplants.
And what's the difference between a solid organ and, say, a stem cell transplant?
So solid organ is what it sounds. So that's going to be our heart, our liver, intestine, and kidney. And then the stem cell is a completely different type of transplant, and that involves a true transplant of the stem cell, which is a versatile type of cell that can grow and develop into a specific type of cell.
And this might be a little too more detailed about stem cells, but so everyone has stem cells?
Correct.
Okay.
And these, I believe, can be harvested from the bloodstream, from the bone marrow, from the umbilical cord.
Okay. And then how do you become a registered organ donor? There's more people on the transplant list than are available, organs that are available. So how do you become a registered donor? I know it's a personal choice, but...
One of the easiest way is when you're renewing your license on the back of your card, you can give permission or sign up for organ donation that way. You can also go to the Secretary of State's website and sign up. And also donatelife.net is another mechanism. I think the issue also is that you should inform your family that is very important to you and that's something you want to do. I think around the time if someone's dying, it's somewhat of a traumatic experience. So for the family to know ahead of time that that's your wishes, that you want to donate your organs, is very important.
And who can be a donor? Anyone?
Anyone can be a donor. It simply depends on your medical condition going into donation of your organs, your size, your blood type. So there are a number of factors that go in to who's a good match or who can actually donate their organs.
Okay.
Yeah, and registration does happen on the state level. So another site that you can access as well is through the U.S. Department of Health and Human Services, which is www.organdonor.gov.
And then not all organ donors are deceased donors. There are some donors who are living donors. Can we talk more about that process?
So for the living donors at Lurie's, we have kidney. We also have liver. I'm more familiar with the liver transplants, living donation donors, and about 20 to 25% of the liver transplants that we do here at Lurie's are actually living-related donations. When you do a living-related donor, it's typically an adult to a child. We work with our colleagues at Northwestern, which is a great group. We work very closely with them, and in order to donate an organ, you must be cleared medically. So there's a very extensive evaluation for for donation, and it can take weeks to months to actually get that done, depending on the urgency of the situation. The donors who are being evaluated at Northwestern actually have advocates who are helping them through this. They see the surgeons, they see the medical team, they see psychologists to make sure that the person is really prepared to be able to do this. Because this is a surgery. This can be a major surgery. And so we want to make sure that the donor is actually healthy also, and that the donor will have as few complications as possible as a result of their donation.
And so we have 2 kidneys. So obviously we can donate one and still live with 1 kidney. The liver is unique, though, because it can regenerate, correct?
Correct. It can regenerate, and that's often we may have parents or other family members who will donate to their children. And so it's called a split donation for livers, because the donor still needs to retain their liver. And so again, the adult people at Northwestern, the adult doctors, make sure that that person is healthy, has minimal medical problems, and that they should have no problem during the surgery or after the surgery.
And so what kind of criteria is looked at when matching someone to, say, a liver donation?
For living related?
Or deceased.
Deceased.
And if why does it vary?
It will vary because, again, you have two patients now instead of just one patient when you do living related. And so you want to make sure that there are no significant complications. Do they have significant high blood pressure? Do they have high diabetes? Do they have sleep apnea? Are there other medical complications or conditions that could complicate their surgery? So you want to make sure you minimize those. You also have to look at the blood type of the patient. And also the size. The liver may be too big to donate. So if you have a smaller infant, if the donor's too big, or the portion of the liver that you're going to donate, if it's too big, it's not going to work. And also, saying that, it can't be too small also. So during the evaluation at Northwestern, they're very carefully evaluating this and doing imaging to make sure and determining if that liver and or kidney would be suitable size for the recipient at Children's.
Yeah, and the matching process is coordinated through UNOS, which is the United Network of Organ Sharing, and they look at all of that criteria for matching: the age, the size, the blood type, tissue type, blood type, all these other things.
And the need of the person
Right.
receiving the organ.
Right, and the status.
The status, okay.
Right.
So when you talk about the status, I'm more familiar with liver transplant and intestinal transplant, but there's a system, it's called MELD/PELD, and it evaluates the patient to determine, based off of laboratory data and other data, how healthy that patient is. And so the sicker the patient is, the higher they are on the waiting list. And so the higher the number is, that patient is more likely to get a graft, because the thought is that patient is sicker and needs a graft sooner rather than later.
We actually have a question from one of our viewers, which reminds me, if you have questions, please submit them in the comment section below the video. So this is a question. My child has been waiting 6 months for a heart. It gets scary to think he may never get a heart. So I know you work primarily with liver and small bowel transplant patients, but maybe you can talk about the waiting period. It's sometimes really unknown, right?
It is unknown because you're basing off, like we said, blood type, size, even somewhat their viral status, is what previous infections that those patients have had versus the donors. So the waiting can be difficult. I must admit, I can't speak to the waiting list time for the heart transplant patients, but they can have a wait, because again, you need that good adequate size, blood type, to be able to make sure that it's a good match. And so for some organs, and each organ system may be a little different how they allocate the organs, but it's very difficult for families. And then I think that's also the importance of encouraging families or encouraging people to donate their organs. I think that we do have a shortage. We do have more people on the waiting list than we have available donors, and I think by encouraging those, that would be helpful. There are over 100,000 people that are actually waiting for transplantation, and only 18,000 deceased donors from 2016.
Wow,
so we
that's
definitely
different.
there's quite a discrepancy in the number waiting versus the number that are actually donating their organs.
And on average, a deceased donor can help save how many lives? I think it was around 50.
It's a large number. I actually don't know the exact number,
but
it's
extraordinary.
It's a large number.
It's more than one.
It's more than 5. Yeah, probably 5 to 7, if not more.
We have another question. How long is the transplant evaluation, and how long is the wait list right now for the liver? So that's, again, the wait could be different for every patient. It's just determined on.
It determines on the size. It's determined how sick the patient is. The evaluation for the patient, if the patient has become sick, the evaluation can be a shorter process. Now, again, when you're talking about living related donors, that process will definitely take longer in the sense of that, again, these patients have to be extensively evaluated because you have 2 patients now. So you need to make sure that you don't compromise one patient for the sake of the other patient. And so that's why that process is totally separate. Here at Lurie's, we don't know anything really about that process that's going on at Northwestern until they tell us whether or not they feel this patient is a candidate or not. In that way, we prevent any sort of any undue pressure, or any secondary gain, and that and it's impartial, total impartial evaluation.
Right, and a lot of team players involved, not only, of course, the family, who has a right to refuse, and are offered alternative treatments, but we have, the primary team, we have surgery involved, we have, as Val mentioned, you have to go through a psychosocial evaluation, we get child life involved, there's, radiology studies, lots of lab work involved. So, but it can be done very expeditiously, particularly for kids inpatient who are very acutely ill.
Okay. So tell us a little more about your roles here at Lurie Children's.
So I am the medical director for the Intestinal Rehabilitation and Transplant program. So that means I take care of patients who have what's called intestinal failure or short bowel syndrome. So for whatever reason, whether it's from a surgical event earlier in life where the child has lost a significant amount of their intestine, or it may be an older child who may have some sort of trauma that they have lost their intestine. So I help maintain them with the help of the team, the multidisciplinary team we have here, maintaining them and trying to maintain their nutrition and their growth and their health while they're receiving IV nutrition. So that's my primary role, to try and taper patients to hopefully allow their intestine to quote unquote adapt or to heal enough where it can compensate for the part of the intestine that's actually missing. So the majority of the patients we actually care for here are successfully tapered from their TPN or their IV nutrition and are able to live somewhat normal lives, if not totally normal lives. Unfortunately, some patients will go on to transplant. Our role here is primarily to taper them from TPN, but there are certain circumstances where we'll not be able to relieve them or allow them to be tapered from TPN, and they will go on to need transplantation. And we are also able to provide that, which is the ultimate therapy.
Right. And you work closely with Dr. Cohran.
Yes, I was just going to interject one thing, that we have about 6 patients actively listed right now for transplant. And so yes, I'm a nurse practitioner. I work side by side with Val and the other members of our team, and I've been in this role for about 3 years. And I provide direct patient care, both inpatient and outpatient. I manage about 30 patients right now on TPN that are home, which is a really neat thing, is that we follow them through the continuum, whether they're inpatient or at home, to provide all of their complex needs.
You mentioned, both of you, TPN. I think for our viewers, can we clarify exactly what TPN is?
Yes, so that means IV nutrition, or nutrition that is given through a catheter of some sort. So that's able to provide them 100% of their daily nutritional needs if needed.
And why would one of these patients need that sort of nutritional support?
So it's due to intestinal failure, meaning that they are not able to absorb adequate calories to sustain life.
And you mentioned small bowel and small intestine. Those are the same organs.
Yes.
And I'm assuming that nutritional absorption is one of the main functions of this organ. Talk about the small bowel and what it's responsible for in the body.
Right, so nutrient digestion, absorption, it's also, there's hormone production, drug absorption, along with fluid absorption as well.
And when we met a few weeks ago to talk about setting this up, I was so amazed at what the small bowel is actually responsible for, and a lot of people don't realize that each section, right, is kind of has its own role. Yeah,
so that's kind of, a very important part when we're getting to know a patient too, is if they have suffered some kind of resection of their bowel, it's really important for us to know what part of the bowel is missing, because it will dictate what they, how they will absorb, and gives us a sense of, will they be able to adapt, or will their intestines be able to handle 100% of their nutrition or not. So yeah, we have 3 different sections of the intestine, the duodenum, the jejunum, and ileum, that all have very different roles and responsibilities.
So we have another question. Why is the small bowel so difficult to transplant? You don't hear about them often.
That's a very good question. I think one of the issues with the small bowel is it contains a lot of lymphoid tissue, a lot of white cells from the donor. And so as a result of that, the one issue you talk about when you think about transplant is rejection of that organ. And so because there's so many white cells, so many lymphoid cells from the donor, and you're putting it into the recipient's immune system is this is foreign. This is not supposed to be there. So because of that, these patients tend to be high risk for rejection, probably one of the higher risk organ transplants because of that. So they require very close monitoring, frequent endoscopies, and higher levels of their immunosuppressive medicine than perhaps some of the other organs, just because they're such high risk for rejection. One of the other things I just wanted to tag along with what Katherine said, when we think about their 30 kids on home TPN, so these mothers and fathers are hooking them up to their IV nutrition, they're taking care of these lines. These kids often have feeding tubes in their stomachs, they're taking care and preparing their formula. And if you look 30, 40 years ago, a number of these children actually probably would have died. Some of these kids would have never left the hospital. And some of these patients would actually have had worsening liver disease and eventually have died. And if you look overall at the numbers for intestinal transplant, it really peaked in 2007 with like about 110, 115. Last year there were only 57. And it's really because of these multidisciplinary teams like the one we have here. We also have surgery that works with us, the social worker, who's also very important with us, the nurses, the whole team to help with these patients and trying to keep them as healthy as possible and keep them out of the hospital.
And really your goal too, even though you are the small intestine, small bowel transplant physician and advanced practice nurse, you would ideally not like to see a child transplanted, correct? So there's various ways you help prevent that.
Yeah, transplant is certainly not a benign decision. However, of course, we're going to do whatever we have to do that's in the best interest of the child and what the family wants to do as well. So
I think that if we can successfully rehab or rehabilitate the intestine, whether it's the way we manage the feedings, the formula that they're receiving, whether it's the way we manage the IV nutrition, the different forms of IV lipids or fat emulsions that we're actually able to provide for these children, whether it's the surgical procedures. Dr. Superina, who's also our transplant surgeon, often does a number of our tapering procedures, what's called the quote-unquote step procedure. So we have a lot of ways that we can try and help these children rehabilitate without transplantation. But having said that, as Katherine said, sometimes the intestine is not going to be amenable to that and the patient will need a transplant, and we're able to do that also.
Can you talk a little bit more about the step procedure or
So a step procedure, okay. I'm not a surgeon, let me just put that up there.
Okay.
But the step procedure is, the actual acronym is for serial transverse enteroplasty, and it was discovered by a medical student in Boston. And this procedure actually allows the intestine to be tapered, so you're able to decrease the size of the intestine, but also increase the length of the intestine. So what happens is if your intestine is very dilated, if you think about a balloon, if you press on a balloon, it won't move very much, okay? And so what will happen is with adaptation over time, these patients' intestines may dilate, and then it doesn't function very well, and it puts them at risk for infections. It puts them at risk to have complications from that. They can have worsening liver disease because of the frequent infections. And so when you determine that the patient is a candidate, that they have significantly dilated loops of bowel, our primary surgeon here is Dr. Superina, and he has performed most of the step procedures that we've actually had done here. I would say the majority of our patients have been very successful, but like anything, sometimes the intestine has such significant issues with it, whether it's motility, it's not moving very well. Some patients will still go on to need transplant.
We know that the heart is ideally like the size of your fist. How large is the small intestine? Is it really small?
The diameter may be small, but it's a fairly large size organ. A newborn infant has about 250 plus or minus 40 centimeters of bowel. Adult 500, 700 centimeters. So much more bowel over time as you get older, but it's not quote unquote small. Definitely not small in length.
Okay. We have another question from a viewer. What is the known duration for a child to be sustained on TPN? Or does that vary?
Yeah, it definitely varies. I think there's a lot of factors. We always say when we're meeting families for the first time, we can't control the age of the patient if they were born premature. We can't control, in large part, if they suffer a septic episode. But we can change the components of the TPN to make it hepatoprotective or protective of the liver. Mm-hmm. So I think that's one of the very important interventions that we do as part of intestinal rehabilitation. But the longest person, I don't know. I feel like there is somebody that was on it for some 40 years.
Yeah,
or
there
something.
was an adult patient that I heard her story. I think I heard him speak at a national conference. He was in his mid-40s and had been on TPN for a long period of time. Now, part of the issue with that really depends on the underlying intestine. So patients who are missing a significant amount of bowel don't tend to be the ones who can be sustained that long, because they potentially will have problems because you're not unable to feed them. You're not as able to protect their liver, so they're more likely to get liver disease. And so there are a number of other considerations that go into if you're able to. And I definitely think, families have the right to choose if they prefer to be on TPN instead of going to transplant. I have no issue with that. And I think we would prefer if we could. Now, once the patient starts having issues, whether their liver starts failing, and we know that before it starts. Mm-hmm. If they start having repeated episodes of infection that we don't seem to be able to control with antibiotics, with ethanol locks, if they start losing their what we call vascular access points, where you can't put IVs in them to maintain them on TPN, those patients need to go on to transplant sooner rather than later.
And a person waiting for a transplant, do they wait here at the hospital or at home, or does it depend on each case?
Yeah, it definitely depends. It seems like our friends in the heart transplant world, a lot of their patients are waiting in-house for that organ. For us, they're at home waiting. So it really depends.
Okay.
And even the livers, if the liver patient is very sick, maybe having complications, maybe they're having significant bleeding, multiple infections, that patient could also wait a prolonged period in the hospital also. Just depends on how sick the patient is. The intestinal transplants don't tend to be in the hospital, but if they are also waiting for liver and intestine, they tend to be sicker, and those patients may be in the hospital for longer periods of time.
Is that a common thing you see, that a patient who's in need of a small bowel might also need a liver or kidney?
It's interesting, if you go back and look at when they initially started liver and intestinal transplants, about 2/3 of the children would always get a liver also. But the way we now manage the TPN and we minimize the liver disease, more and more of these patients are only getting isolated intestines.
Right. So, yeah, for perspective, we have one of our 6 patients is awaiting a liver and intestine.
That's great progress that's been made, and I'm sure really awesome to see. The support that we offer our transplant patients, I think, is unique here at Lurie Children's. It's not just a physician and an APM, but we have a whole team in place that really provides family-centered care. And I was hoping that you could talk about that.
The one thing I did not mention, who's an important part of our team, and I feel remiss, our dietitian. The dietitians are very important, especially when you're dealing with nutrition and fluids and electrolytes. And Carmen Thompson is our primary dietitian, so I'd be remiss without mentioning her as part of our team. I think that social work plays a very large role here at Lurie Children's. We have a very strong social work department, and whether it's helping families get to their appointments, whether it's perhaps helping families organize their days, organize what they need to do to be able to get their child listed or help them after transplant, whether it's helping even from a psychosocial standpoint. I think that we play a large role in that, the social workers and the psychologists here, to help these families, because it is traumatic. You have sometimes an infant, a 3 or 4 month old, that's undergoing a a transplant. And so I think that that's a very important part of it. And I think we all recognize the potential toll this will play on families, and how long they may be in the hospital. The previous questionnaire mentioned 6 months. Her child had been waiting.
Mm-hmm.
You know, it may be longer than that before they actually get an organ. So,
and we rely heavily too on our child life program as well as our chaplains.
Right.
You know, a lot of our kids need a range of therapies too, because they become deconditioned while sitting in the hospital.
Mm-hmm.
So physical therapy, speech therapy
Mm-hmm.
is very heavily utilized with our patients. Occupational therapy, so it's definitely a multidisciplinary approach.
Even school services.
School services,
yes.
Which we should
Our
mention.
kids.
Mhm.
Yeah.
We have 2 teachers on staff,
Yes.
and Chicago Public School teachers as
Mhm.
well.
Yep.
So they don't get away from their schoolwork.
just because they're in the hospital.
Right. So let's talk about after transplant. What does a patient and a family, what can they expect?
So if you think, again, I'll talk about more
Right.
the livers and the intestine. For an intestinal transplant patient, it is still a very intense process, because just because the organ was placed doesn't mean that they're going to be automatically taken off their IV nutrition. So that intestine also has to heal from the surgery. So it can be some months after the surgery before that patient is actually tapered from their TPN. They may be in the hospital. I think the shortest stay I've had is about 2 weeks. I've had patients who've been in the hospital for several months after transplant. Again, for intestinal transplants, they require frequent endoscopies or scopes, simply because we need to be very on high alert for rejection. Again, going back to all the lymphoid or white cells that you have put into the intestine that put them at risk for infection. For an intestinal transplant, I typically will do an endoscopy maybe weekly for the first 4 weeks. Then I may go to every other week for a few months, and then go to monthly procedures. Now, again, if something changes, if there's some concern about their condition, they will get an endoscopy done sooner. They get frequent lab draws, because I always have to make sure that their immune suppressive medicines are at good levels. They tend to still have diarrhea, so I tend to have to monitor their electrolytes and adjust their TPN, their IV nutrition, and their enteral feedings frequently. So it doesn't totally, just because you were transplanted, especially for intestine, doesn't mean it's all over. It can be a long process, but I think as we've seen, there's some patients who are doing extremely well, and it can be an intensive process. When you think about livers, again, it just depends on the donor, the size. Was it a size match? Were there any complications after the procedure? But some of these patients can be out of the hospital sooner rather than later. Liver's a little bit different. They also get their blood drawn frequently, but not nearly as to the extent of the intestine, because of the amount of lymphoid tissue that's present in the intestine. They frequently come back for clinic visits. Okay, they get to see us frequently. They may also, if they get a fever early post-transplant, liver or intestine, will likely get readmitted into the hospital for observation, because their immune system is so suppressed because of the medicines we have them on. We always have to watch for life-threatening infections, whether it's bacteria or viral infections.
Right, and we utilize, I know liver and intestine, I don't know about the other programs, utilize the wonderful Ronald McDonald House as well as sort of a transition or bridge to home, so that families take full ownership of the care again, with all the new medications and stuff, and they're, a stone's throw away from us if there's any concerns.
But they can go back to school.
Yeah.
Sports.
We definitely encourage that, yeah.
One of my patients who is about 8 years out now actually plays ice hockey. So definitely you can do anything you want to. She's in school. She's doing well. So there are a number of patients who are able to go on to live normal lives. You may see them walking down the street and you can't say they had an intestinal, liver, kidney, or heart transplant.
Right.
They look like everybody else.
That's amazing. So I think we'll just recap some of the questions we answered at the beginning for people who might have joined us later. But again, what type of transplants at Lurie Children's do we perform?
We perform heart, we perform liver, kidney, intestine, and stem cell transplants.
Okay. And what's the difference between a solid organ and a stem cell transplant?
So that solid organ is what it sounds, is going to be an actual organ being transplanted, a liver, a heart, kidney, intestine, versus a stem cell, which is a versatile type of cell that can develop into a variety of different cells. And this can be procured from peripheral blood, from umbilical cord, or from bone marrow.
We mentioned the small intestine or the small bowel and why we don't perform as many, say, like a liver or kidney. Why is that? I think it doesn't last as long outside the body, or once it's harvested.
Yeah, that was one point we didn't touch on too. Is sometimes the intestine is referred to as sort of a selfless organ in that it's going to divert the blood flow to the vital organs. So it does limit us geographically in where we can get organs from because of what's called the cold ischemic time, or that actual clamping when you're taking or procuring the organ and bringing it to the recipient. And then Val talked about
that definitely will place a limitation, because we cannot, if the intestine has not been well perfused for 10 to 12 hours, it's not going to do well potentially in a patient, versus the liver and the kidney tend to be more resilient from that standpoint. And I think also overall we just do less intestinal transplants throughout the country because of our ability to rehabilitate these patients, and they don't need transplantation, whether it's surgical interventions like the tapering procedure or the step procedure, whether it's managing their TPN or IV nutrition differently with different liver protective manners, whether it's different antibiotics or ethanol locks that we're using to minimize infections. So I think throughout the country we're just seeing less intestinal transplants being performed because of everyone's ability to be able to manage these patients and hopefully successfully taper them from their TPN.
Which is a good thing.
Yes.
And for our viewers, can we remind them how to register to become an organ donor?
I think there's a few ways. Yeah. It is very state by state. But one site is through the U.S. Department of Health and Human Services, which is www.organdonor.gov. And the other one was
donatelife.net. And also, when you register in the state of Illinois, at least, for your driver's license, you can sign up for organ donation there. And the other issue is to really emphasize that you let your family know your wishes and that you really strongly want to be an organ donor.
I think we'll have time for just one more question. The GI liver, maybe it's just a comment to you guys, a shout out. The GI liver team at Lurie Children's is the absolute best. My family feels blessed that they handle my son's care. God bless them. So I think that's a nice way to end.
Thank you.
Again, this is April's Donate Life Month, which is this great informational piece. And if you would like to register for to become an organ donor, I will post the information that Val and Katherine provided us in the comments section below. Thanks so much.
Thank you.
Thank you.